heads up of what next week is going to look like. Today we're going to talk about your research articles that are on treatment, CBT versus ERP, and then there is sort of a case study / research article on deep brain stimulation as treatment for OCD. On Monday, we will have 3 video case studies, and then you'll have a worksheet to sort of complete as we watch those in class together. And then on Wednesday, you have your 3rd sectional exam. It'll be just like the other 2 sectional exams. It'll be all free response questions, and you'll have some choices on which ones to answer, okay? I have a conference next week that I'm going to, and so I will not be here on Wednesday. Ms. Foster will be giving the exam to you, and we will not have class on Friday. So happy Aloha Friday for next Friday as well, okay? Questions? Okay. After that, I mean, since we're on a roll with the schedule, we have 2 weeks left, that's it, right? So, and in those last 2 weeks, we're going to cover addiction and depression and depressive disorders, and those will be on the final exam, which will be cumulative, including those 2 new topics. And the final exam will be just like the other exams. It will be, written response questions, sorts of things. All good? Any questions? Awesome. Okay. So, just a reminder, here is our DSM-5 criterion for obsessive compulsive disorder. Any questions about that and about what we covered on Wednesday? No? Good? Okay, cool. Just to sort of remind you of the treatments that we're about to talk about in our research paper, right? We have the primary first line treatments are cognitive behavioral therapy and exposure response prevention. And so just to remind you, cognitive behavioral therapy has these 4 components associated with it, right? Relabeling, reattributing, refocusing, and revaluing. And ERP is where we are working on the behavioral component, where we are exposing to a trigger for the obsessive thoughts, and then preventing the response of the compulsive behavior, and substituting that compulsive behavior with effective coping strategies to change the cognitive obsessive thought pattern. Okay. All right, so CBT versus ERP publication. So a little bit of history that ERP, exposure response prevention, was sort of the first therapy that was developed, and cognitive behavioral therapy was later sort of proposed as an alternative to ERP. And so several studies then, including this one, sort of looked at comparing the effectiveness of CBT and ERP, right? So what is the primary sort of focus of cognitive behavioral therapy according to this paper? What are they trying to address? When doing CBT?
ERP that hasn't been super successful.
Okay, but all right, yeah. So that's why they're trying to have a different type of test out new therapies. But as a therapy, what is CBT trying to do?
Recontextualize thoughts that you don't want and turn do the four things so that the end result is having thoughts that are healthy and not having the thoughts that are unhealthy or the compulsive behaviors.
Yes, right? So we're trying to address the distorted cognitions, right? And lessen the anxiety-provoking stimuli. So what have previous studies found? In the introduction, what do they talk about previous studies found?
ERP wasn't like the most, it wasn't terribly effective. I mean, it was like 75%, 60 to 70, but it wasn't like the most effective treatment that they thought that there were better long term. And that as you do ERP longer, like after a long period of time, it kind of loses its effectivity.
Okay. And so previously, what has this lab done? So this study is actually a follow-up study to a previous study that this lab had done. So what did they do previously?
I didn't notice that this was like this own lab that was redoing it.
So the previous study that had been conducted earlier was same lab and compared the ERP group and the CBT group. And yeah. And they did it they did it for like intervals of 3-month follow-ups.
Okay. But what was specific about that study? What's different between that study and this study? You said it, but you didn't exactly say it correctly. Everybody look at the last paragraph of the introduction, or second to last paragraph of the introduction.
Look at CBT.
And what type of CBT and ERP did the previous study do?
Oh, group versus individual.
Yes, right? So what they did before is they had group therapy. They compared group therapy of CBT compared to group therapy of ERP. And what were the 3-month follow-up success rates?
44% versus 13%?
Yeah. So at 3 months following group therapy, the group therapy for ERP had a 44% success rate, and the CBT had a 13%. What do you think about those numbers?
I mean, I think that looking at those numbers, it's easy to think that CBT was just like an effective and isn't a great like therapy in general. But then when you actually like understand CBT, it's hard to do on a group scale because not every person has the same like thoughts and way of thinking and like obsessions and compulsions.
Mm-hmm. So why do group therapy?
I think because it offers like a support system
Okay, it can offer a support system.
and it encourages, I think ERP can be really scary for a lot of people, and I think like people with OCD especially, like my sister has OCD and I was telling her about our ERP and she was like, I would never do that. So I think like it's definitely, they're really reluctant to do it, and I think being in a group makes it more likely for them to do that.
Okay, so I'll also throw out there that group therapy is more cost effective, right? Because you have one therapist with a group of people as opposed to, let's say there's 10 people in the group. So instead of having 10 individual therapy sessions, you have one therapy session for 10 people. And it's, you're billing 10 people for 1 hour and you're only working 1 hour instead of billing 10 people for 1 hour, but you're working 10 hours. right? So, some of this, we do have to recognize sort of the societal pressures and influences that we have, right? So there's a cost associated with these. We want people to get better and be healthy, but you have to have insurance, and you have to pay for this stuff, or you have to pay out of pocket, and it's not cheap, right? So there are some pressures to do things like group therapy, not just for the benefits, and certainly there can be some benefits, as you mentioned, AJ, about having group therapy in terms of support and and that sort of thing. But also there's these societal pressures and influences that are also acting on that. And I think, Lily, what you and AJ both said is right, that you think about what encompasses CBT, right? It is learning your individual obsessions, right, and how to cognitively change those patterns, which is going to be probably a more individualistic type of thing that has to happen, right? And if you're in a group and you're trying to do this in a group setting, you can kind of see how it may not be as effective as we see here. Whereas ERP, it doesn't kind of matter what your compulsion is. You're learning to prevent the compulsion, right? And doing that might be easier to do in a group sort of setting, right? And maybe even more beneficial, as you mentioned, to having a support system there, and we're all going through this together sort of thing, right? So what was the aim of this study?
It was basically to compare the efficacy between for OCD between CBT or ERP, but it was individual.
Yeah. So now we're going to say, okay, is it really that CBT isn't a very effective therapy compared to ERP? Or was it maybe the group setting that we've kind of identified that maybe this isn't a good thing to do as a group? Maybe we do need to do, right, individual therapy instead, right? All right, so method. What are the neuropsychological tests that they were doing here? Where there are things that they're measuring to see if people get better?
They're using the Yale-Brown Obsessive Compulsive Scale to measure the severity of OCD symptoms.
Yep. So the YBOCS, right, has a range of 0 to 40, 40 being the worst, 0 being the best, right?
They also used a structured clinical interview.
Okay. And what other things were they measuring?
Reaction to treatment.
What'd you say?
Reaction to treatment.
What'd you say?
They're also looking at the back depression inventory and social depression.
Okay. So sometimes there's comorbid expression of depression, right, with this as well. And what else? They had 6 things, right? 1, 2, 3, 4, 5, 6. Easy to identify.
Responsibility interpretations questionnaire.
Okay.
Obsessional belief scale.
Okay.
Interpretations of intrusions, inventory, and homework compliance.
Yeah. So let's pull all this up, right? So the obsession belief scale is on a range of 1 through 7, right? And there were 3 different subscales of that: responsibility, harm, perfection, certainty, and importance, control. They looked at an intrusions inventory, right? So these are the obsessions or intrusive behavior or intrusive thoughts. And the reaction to treatment, and then they also looked at homework compliance. Why is that important?
To see if they're adhering to the treatment and doing their homework.
So what do we say is like a critical factor of CBT?
Effort and being conscious about what you're doing.
Yeah, right? So you have to have buy-in, you have to have clients that are willing to work outside of the 1 hour a week session that you're having with them, with the individual. So remember, we're doing individual treatments here. All right, so what were the treatment groups? What did they do? What were the manipulations here, or independent variables?
They were randomly assigned to receive either CBT or ERP.
Okay? And how long was the therapy?
50 to 60 minutes, and were delivered over 12 weeks.
Okay? So they had 12 weeks of basically 1 hour sessions, individual. For ERP, what was the focus? What delineated the difference between ERP and CBT?
Negative reinforcement from like seeing, or like trying to rewrite the negative reinforcement from the obsession and compulsion.
Yes. And what was sort of the thing that they were focused on with ERP not doing? What were they focused on not doing in the ERP?
They were focused on not responding to like a discussion of cognitive issues.
Yeah, they were really trying to prevent any like creep of CBT into the ERP, right? So they were looking at habituation. They're trying. So what does it mean, habituation to a triggering stimulus?
Like the more it appears, the less you react to it.
Yeah. So habituation is where you have a stimulus, and at first you may really respond to that stimulus, but the more times you present it, the smaller and smaller and smaller that response gets. Is the idea, right? Whereas sensitization would be the opposite, right? So we're talking about. Again, what are those terms associated with sensitization and habituation?
Like conditioning.
Yeah, subconscious learning conditioning, right? So we're trying to uncondition these associations. All right. And CBT, they were specifically interested in challenging the appraisal of intrusive thoughts. So that whole four components, right? Relabeling, refocusing, reattributing, right? Okay. And not working on habituation to ERPs. They're really trying to delineate these two in order to compare sort of their effectiveness. All right, what did they find? It's all in table 2.
Did they see an increase in CBT, or is it a 4% decrease?
Where, so here on this figure that I have up here, what is important?
Degree of post-tests, and there's a reduction in the post-tests for both, and it's close to similar.
Yeah. So the Y box, right, is the measure of obsessive compulsive symptoms, right? And remember that scale was 0 to 40, right? And so on average, people were coming in at 23 and 22-ish, so pretty similar for each group. That's good, right? And both groups, CBT and ERP, saw similar reductions, right? And in their the severity of their symptoms, right? And their follow-up at 3 months was what?
CBT kept going down, ERP went a little back up,
Pretty much stayed the
but
same.
pretty much
right? I mean, both of them pretty much stayed the same, right? Why do you think maybe CBT improved a little bit more maybe over the 3 months?
I think because CBT is like, it's a treatment where you can take it with you and you can use it outside of therapy, like you said, and you're practicing it so much with like doing your homework, so like it becomes a habit to you.
Yeah, and speaking of homework, the homework compliance was similar for both of them, right? So that was good. All right, so in terms of numbers, so that's the severity, right? They also reported percent like successfully treated, right? And so those were a little bit higher for CBT, but both of those were pretty good, right? 67 and 59%. That was immediately following. At the 3-month follow-up, right, ERP stayed the same. CBT actually, another 10% of the people reported as successfully completing that. So, like AJ mentioned, you know, ERP, you're sort of learning to disassociate the compulsion with the thought, but you're not getting any treatment or therapy necessarily about the obsessive thoughts, the intrusive thoughts, right? And whereas with cognitive behavioral therapy, you are building this toolkit that you can continue to use, this cognitive toolkit that you can continue to use, and so they saw this continued improvement in therapy, right? What about depression?
It also had a decrease, it was larger, it looks like for the ERP than for CBT.
Yeah. I don't really know what to make about that. The depression is on a scale of 0 to 60, so those are pretty low numbers. So maybe not as big of a comorbid condition of depression with this as they maybe thought they were going to see. Yes, just
What's considered like a high score?
a high score. Well, the range is to 63, so I don't know what I don't know off the top of my head what the clinical threshold is to say that if you score this, yeah, maybe that you're clinically depressed. So slight improvement there. Okay. In the obsessive belief scores, right, all of those showed significant decreases, right, from the pre to the post. So overall, what do you think about the success of individual therapy, both ERP or CBT? What does this study tell us?
It's telling us that they're both pretty effective, similar, like efficacy in both, but relatively effective in decreasing symptoms.
Yeah. And what did we see with the group therapy, the previous?
CBT was not very effective. ERP was 50-ish, maybe 44.
Right? So, you know, comparing these numbers, CBT 76 to CBT 13, right, really gets at the fact that, hey, if you're going to do CBT effectively, it can't be in group therapy. It needs to be one-on-one, right? ERP, could you do group therapy for ERP?
Yeah.
Or does it need to be individual? Yeah. I mean, 58 to 44, there's a 10% difference, right? Because you're probably having that one-on-one personal interaction with the clients, right? But you could probably get by with individual therapy for CBT and group therapy for ERP, right? In a pinch. So what do you, okay, so let's talk about the abstract that I posted. I didn't have you read the whole article, just the abstract, right? What did you think about this? What did they do in this study, first of all? What was the aim of this study? That's the next page. I'm talking about the, just, not the next publication, the abstract that I posted.
They wanted to do clinical trials with BTC, like test efficacy for treatment of, like, is it the onset, early onset OCD? So is that in children?
Yeah. So what is VTC?
Video teleconferencing.
Yeah. So why? Why do that? So they're looking at children 4 to 8, right, that were showing symptoms of OCD. And they wanted to know, could internet-delivered video teleconferencing of family-based CBTs? So there's a lot in there. There's the video, the VTC part, and then there's the family-based part. Tell me about each of those and why you would want it, why those are important in this.
So if you're looking at kids when you're doing like therapy that requires homework and requires upkeep, if it's a kid, and especially if it's 4 years old, the parent's gonna have to be the one who's like kind of leading the charge with keeping up with all of that. The 4-year-old's not gonna be able to do that.
Yeah, right. So individual therapy for a 4 to 8-year-old child is not going to be super effective because you're relying on someone who's not really cognitively developed to do all these things that you're asking them to do. So it needs to be family based, right? What's important about the VTC part?
Makes sense.
Well, what did we talk about at the beginning of class? We talked about why they tested out group therapy. What were the pressures?
Cost effective.
Cost effectiveness, right? And access, right? Not everybody has access to go to a clinic, go to see a counselor, right? So if we can show that this is effective, that's a good thing, right? We can reach a lot more people, we can help a lot more people, they don't have to be in our area, right? They don't have to travel. Kids are in school, right? So that's a time constraint. So this is much more, provides a level of flexibility, right? Okay. So what did they find?
That there was a treatment retention and cognitive engagement across all conditions. And there was, roughly about 13% kind of maintenance and improvement at follow-up.
Mm-hmm. And how did it compare? So they're what are they comparing the VTC to?
Like clinic pieces.
Yeah, individual therapy, like people that are going to a clinic, right? And so they find a little bit better actually, right, than the people going to the clinic. And follow-up, this remained effective, right? All right, so what do you think the best therapy for obsessive compulsive therapy, obsessive compulsive disorder is?
CBT.
I think probably a mix of both would be, I would want to look at a study, but I would probably say that a mix of both to have the stimuli that's negative, so you can do the CBT with the exposure.
Yeah. So that's probably the most effective therapy. And on Monday, we're going to see 3 different types, 3 case studies, right? One young lady is going to do sort of traditional CBT, ERP counseling with a therapist. Right? Another one is going to do CBT, ERP, but in a intensive, every day, I think it's a 14-day treatment plan, right? So the typical, what is the typical CBT treatment plan? What did we see in the previous week? Yeah, once a week for 12 weeks. And so one of the case studies is gonna do that. I'm trying to remember their names. I can't remember their names. But, and then one is going to do sort of a compressed timeline intensive therapy that is every day for 2 weeks. And then the third young man that's in the program is just on medication and without therapy. And so you'll be able to sort of compare their outcomes from those case studies and look at, okay, what is the difference between just treating with pharmaceuticals versus intensive therapy or long-term sort of therapy, right? Okay. All right, so last thing, last paper. What is severe, so this is severe treatment resistant OCD.
You're asking what that is?
Yeah.
It's like it didn't treatment resistant. It's OCD that after undergoing treatments, I think maybe through medication is included, but like it's just not getting better. And instead they're like kind of compounding and starting to go into other aspects like socialization, other like just kind of normal life in general, besides just that generalization.
So what all can you tell me about this paper? Did you notice anything different about this paper than maybe some of the other papers we wrote? Well, okay. All right, so yeah, this paper is, and I picked this paper on purpose because it's a non-Western medicine paper, and I think it's important for us to sometimes reflect on the fact that not all countries have access to the same sorts of medical resources that we have access to maybe in Western civilization than in some of the countries that are maybe less developed or have restrictions. So what are some of the challenges that people trying to do this sort of thing in Iran face? And this is a recent paper, right? When was it published? Yeah, 3 years ago, right? So what are some of the challenges they face? What can you imagine? It's not in the paper, but do you know anything about Iran?
I mean, it's very expensive to get treatment over there, and healthcare is often limited to men or people that have a lot of money and are able to pay, upfront out of pocket.
Yeah, so what do we talk about the prevalence of OCD in terms of genders? Much more prevalent in women, right? And as a society, there are inequities that we hopefully don't see as much in America. It's something that we've tried as a country to work on reducing inequities, whereas in some other countries that's just part of their life. So here we have a disorder that predominantly affects women. The 4 patients in this study were all what? Women, right? And healthcare is sort of limited to people that can afford it. Right? There's also, in addition to gender inequity, there's also socioeconomic inequity in these countries as well. And in terms of their delivery of sort of like high-tech types of treatment, like implanting electrodes into the brain, right? There's some challenges there as well. Their medical system is not as advanced because of the fact that
Education is not really prioritized as much there.
yeah, and the government resources are not poured into those sorts of things, right? And they've had sanctions on them economically from other countries for political reasons for a long period of time, right? So all of these things sort of impact this, right? So I think sometimes it's important, for us to, think about diversity globally and not just like think about what happens here in America, sort of thing, right? Okay, So they screened 40 patients, and 4 of them were chosen for DBS treatment, right? So who can tell me about patient 1? We're going to go through all 4 patients. Who can tell me?
She was a 34-year-old woman. She was suffering from OCD since she was 12 years old. Her obsessions were like an excessive concern for animals, need for symmetry, concern for illness, and fear of making mistakes or losing things. And then her compulsions were excessive hand washing and showering. So she had a significant improvement in cognitive functioning and OCD and anxiety scores, but she got pregnant and her condition worsened after she got pregnant. But they said that before she got pregnant and before she left, that her scores were significantly improved.
Okay, and we'll look at this. All right, someone other than AJ, tell me about patient 2. I'm going to make each person talk about something. There's 5 of you. One of you gets off the hook.
Patient 2 was a 25-year-old woman who had OCD for several years. She didn't respond to long-term treatment.
What treatments had she had?
She had medications I cannot pronounce.
How many? 4 different
4 medications.
medications.
And then ECT sessions.
What's ECT?
Is it therapy?
Yeah,
Yeah.
pretty severe.
Yeah. She didn't respond to any of those. After 6 months after her implantation, her state was good. Her OCD symptoms were reduced, and favorable conditions were reported. Then a year after the DBS, the patient showed improvements on the Y-box and the anxiety score, and she was very satisfied with her treatment.
Okay, what about patient 3? Someone else.
She had severe OCD and was also hospitalized a bunch. She backed down a bunch of different medications, and then she didn't really like the treatment. She said that it wasn't effective, and so she was still on medications after that. She didn't really improve, and then when she had the implantation, since she didn't find any efficacy of it, the battery was turned off and she exited. So there was no, they didn't really evaluate after that because she dropped out, but she didn't really have great results or great outcome.
And she had a 67% decrease in visual memory.
And they were having suicidal thoughts.
That's what it
Okay. What about patient 4? Hold on just a second. My research student's here. Yes.
Hey, sorry. The password and username aren't working for the MS-1 system.
It's the same as it was, the site number.
Yeah.
All right, I'll be there in 5 minutes.
Patient 4.
Yeah, tell me about patient 4.
That is a 30-year-old woman who had severe convulsions, and she had been resistant to all prior therapy. She saw mild improvement. Her Y-box dropped from 38 to 27, which is like a 20-ish% decrease. But she wasn't satisfied, and her symptoms did worsen subjectively, like when she was, telling the doctors how she felt, even though on paper she improved. And then the battery was never replaced after training, and then she didn't see any cognitive improvement, so there's not really a change in executive function or cognitive, or memory, cognitive function.
So what you guys sort of summarized, right, is that here's their baseline. What do you notice about their Y-box scores compared to the previous table 2 that we looked at?
They're higher.
A lot higher.
Yeah, by 20 points.
What is the maximum you can score on the Y-box?
40.
40.
One's at 38.
Yeah. So very severe symptoms, right?
I almost feel like that honestly might be genuinely because of the demographic. Just because, if they don't have access to even really resources, because women in that kind of society are not supposed to complain or voice any kind of issue. So not only are you suffering, but you're suffering in silence and being condemned for ever speaking about your suffering, internalizing that for even a short period of time, I feel like would severely exacerbate symptoms.
Yeah. So, what do you notice at the 4-month there in the purple?
Case 1 is doing great.
Yeah, patient 1 and 2, pretty good, right? 0, I mean, can't get better, right? 9's pretty good. What was the average treatment severity in the previous study that we looked at? It went from about 22, 23 to what?
I'm gonna say like 10-ish.
Yeah, 9, 10, so that's pretty good, right? What about patient 3 and 4?
They went down, but like not as much as the first two.
Yeah,
But I
barely.
would have really like justified open brain surgery.
Right. What do you think's happening there?
It could be a placebo, like where they think like they're getting better, but they're not.
Or maybe they are, like, the efficacy is higher early on because they're buying in more and more willing to work hard and just talk through some of the more tedious parts of treatment, but then they start kind of losing trajectory, or I guess case 3.
I mean, you're talking about the timeline. We'll get to that in a minute. But just looking here, right? Why do you think dramatic improvement, no improvement? What do you think's going on there?
I think it could be like, you know, I've just started this thing, it's working great, but it could also be for the cases 3 and 4 that they're more critical of their symptoms, and so they've been paying attention to them more for these last 4 months and like trying to identify more consciously like all of these symptoms, and so they could be like more likely to report them.
Okay, what is the treatment that they were
Or is it possible that they're in the wrong brain area for those patients?
There's some difference in neuroanatomical.
Yeah, right? So, you know, we're talking about challenges of doing pretty high-tech sort of procedure. Maybe they just missed the area, right? If you're not in the right area and you're stimulating the brain, you're not going to see improvement. And that's what this is showing me, is that, you know, maybe you missed the treatment area, right? Okay. And they also measured, they had 2 different measurements.
For anxiety.
It's
Right.
kind
So-
of sad that patient 4 like gave up on the treatment because it did look like she was improving some.
Mhm.
Like overall.
But then her family members said she was like violently suicidal, or not violently, but she was like really badly suicidal, like worse than she'd ever been.
Yeah.
So.
And so we saw this initial sort of effect of reducing in terms of anxiety. Here we have 2 responders and 2 non-responders, right? So if they miss the area here, which it kind of looks like, right? Maybe here this was placebo, right? They think they're getting treatment and so some of those go away, right? I mean, 2 of them are getting actual treatment, but 2 are maybe not, right? And then why do you think that it dissipated over time somewhat?
Maybe like habituation within the brain to that exposure. Like the brain is like, oh, I still have this, maybe not physical thing that's causing my OCD, but like these are it's still like something, you know, that could like physically manifest again. And so it almost like kind of works around it and kind of reestablishes different pathways.
Could be. So what are they not getting in these months after? I mean, they're having the brain stimulation, what are they not getting?
They're not getting like active treatment, like
Any other
CBT
therapy,
or like
right?
therapy.
Right, we're just turning this thing on. And they talk about these batteries, when do the batteries run out?
Like 7 months and 10 months for some of them.
Yeah, right, which is pretty low. Like, again, these are not state-of-the-art DBS machines. Batteries of things that we're implanting in America are lasting years. And these are lasting 10 months, right? So maybe they missed the area, maybe the DBS just isn't a very good DBS stimulator. They are in the area, but it's just not doing a very good job, right? So lots of challenges here work with this sort of stuff. All right. Questions? Good. All right. This is a sort of summary slide. I posted this, but just sort of reminding you that we have this loop that's broken with OCD and a conditioned association between the anxiety and the motor compulsion response, and 4 different types of therapy, right? We can have neuroanatomical, neurochemical, or neurophysiological in terms of lesions, or we can have behavioral therapy, or we can have psychotherapy, behavioral therapy.
So deep brain stimulation, they're not actually lesioning the brain or anything, they're like, it's not.
I'm sorry, this is the lesion, the neuroanatomical.
Yeah,
But, yeah.
so it's just like the neurophysiological, it's just stimulating response, it's not affecting.
We're changing the electrophysiological responses, the signaling.
Does the premotor cortex have anything, does it play any roles or no?
I mean, it's all wrapped together, right?
Okay.
So, I mean, yes, a lot of those compulsive behaviors are originating in premotor cortex. But the motor cortex loops through the basal ganglia